Michelle. Welcome everybody to today's CAPS Town Hall. I'm really pleased to introduce our wonderful speaker, Dr. Shiri Sadeh-Sharvit, who's going to be talking to us about From Clinic to Home AI Infrastructure for Chronic Care and Family Engagement. So Dr. Sharvit is a clinical psychologist and co-founder and CEO of Resolve Together, which is an AI platform building infrastructure for family-driven chronic care management. I was really excited to meet Dr. Sharvit a few months ago and talk about our shared interest in couples work and really the importance of engaging family members and partners as key members of the care team. So as you know, most of the care actually happens at home. And so this is a really important opportunity to engage family members in care. Dr. Sharvit was previously the Chief Clinical Officer at Eleos Health, where she helped develop the first ambient AI documentation platform for behavioral health care. She's also a distinguished professor of research at Palo Alto University, specializing in couples interventions and behavioral health. And her current work focuses on designing AI-augmented care models that enhance clinical decision-making and behavioral interventions while preserving the central role of human relationships. So without further ado, I will hand it off to Dr. Sharvit to lead us through her presentation. If there's any burning questions, we can take them as we go. We want to make this conversational and have as much discussion as possible, but you're also welcome to put your comments and questions in the chat, and we can leave about 10, 15 minutes at the end to talk about them. All right, take it away. Thank you.
Okay. Thank you so much, Amy. And hello, everyone. Thank you for joining us today or viewing this webinar later through the YouTube channel of CAPS. Before I begin, I'd like to thank Dr. Amy Conroy and Rochelle Blanco for inviting me to present today, and to John Amiga. I don't know if he's here for posting about this talk on social media. And today I really want to step back and look at where AI actually fits clinical care. We hear a lot about AI this, AI that, AI is risky, AI is going to take our jobs, or our kids and family members and patients are going to have romantic relationships with AI companions and so on. There's a lot of excitement and a lot of worry, and also a lot of confusion that I hope that I can share this today in this talk a little bit about how I perceive this landscape, what I can effectively do these days, and what are the really interesting opportunities to engage artificial intelligence based platforms to enhance interpersonal connections, and especially in the context of chronic care. So I'll really walk us through today through three things. First, where AI is currently being used in clinical practice, where the limitations are, especially in behavioral and relational contexts, and what it would take to extend care beyond the clinic into the home, where most of chronic care actually happens. In terms of my disclosures, as mentioned, I'm the CEO of Resolve Together. In terms of my personal background, I'm a clinical psychologist, as mentioned, served as the researcher at Stanford for a couple of years. And over the years, my work really centered on behavior change and what actually happens in real life, not just in clinical sessions. In the fields of weight management conditions and eating disorders, I was one of the pioneers to pull in the adult spouses and partners of patients, adult patients with eating and weight management conditions. And more recently, I've been studying how these digital tools, specifically artificial intelligence, can augment clinical care and support decision making. So the lens that I bring today is on the one hand as a clinician, on the other hand as a human being who thrives in relationships, but also as someone who worked in the system and really thinking how we can design tools that actually fit how care unfolds into the real world. So let's start with the term augmented intelligence. When I think about artificial intelligence, I think about bots and different types of automation where you delegate a task to AI, go do your own thing, come back, and then you receive the findings. For instance, administer PHQ-9 to all of your patients at certain cadence, and then see whether there is any information that is being flagged. In clinical settings, the concept of augmented intelligence is often more useful than artificial intelligence. Augmented intelligence shifts from AI replacing aspects of our work to a supportive tool that enhances human thinking and really thinks about the human, here the therapist or the trained provider who receives information and inputs and data from artificial intelligence bots or other tools, but then makes their own decisions based not only on the data, but also on their intuition and what they see in real life. And I can give an example when I um, worked at Stanford, and I was one day in a hurry to pick up one of my young kids from school, and I used Google Maps. And at some point, Google Maps in Palo Alto, really near Stanford, told me to take a left turn. I was in a hurry. I did not think of this through. And although I did see in my own eyes that there was a sign, no left turn between 3 to 6 p.m., I did take that turn. And the police officer who was waiting after the junction a few feet further where they were hidden really didn't like the idea that, oh, the AI recommended that I take a left turn. And we had a really nice discussion about who's really driving now the car, which was valid. But it's a really great example that rather than replacing clinicians or replacing human relationships, AI can function as a support system while the therapist or the human and their families are still in the driver's seat. But still, in my defense, I will say that it was also not Google Maps, but me who negotiated with that police officer to reduce the fine from $100 to $25. So you see that over time, our skills and the interpersonal aspects of our work and our relationships still matter more than uh, technical or formal requirements or recommendations of AI. Um, and in behavioral health, I think this distinction is primarily important because our work involves interpreting complex relational dynamics, context, meaning, the kind of intuition that only us can bring to the table because we are human and we meet another human being. And these are the areas where the human judgment remains essential, just like, deciding to take a left turn because you're in a hurry, but what you see in your own eyes tells you differently. And throughout this talk, I will frame AI as something that extends human capacity and not necessarily replace it. I know there are many use cases where AI replaces human relationships. I will not delve into these issues in this specific talk. I heard that you have many talks in April, and I assume that some of them will talk about tools that could replace some of our work. So moving forward, I'd like to rely on a model that was developed by Stephen Holland from Vanderbilt University and myself to illustrate how AI is integrated or could be integrated into clinical practice. if we consider the workflow of us as providers, there are several domains where technology and specifically artificial intelligence can provide support to us in our work. Um, the first step, of course, is the screening and personalization. We hear about it all the time in other domains of health, personalized medicine, personalized treatment, and so on. This is one aspect where we can talk, when we can review different aspects of AI tools and how they extend or replace some of our work. Another aspect is measurement-based care. It's being integrated more and more into our work, not only in academic settings, but also in community settings where value-based care models have become more and more prevalent, where the patient is expected to complete a few tools and assessments in a regular cadence, and the improvement in outcomes and is measured over time more systematically and objectively. There's also the aspect of apps and chatbots, and this is a whole world of what happens between sessions. Long gone are the days where, Freud in the end of the 19th century expected his patients not to make any important life decision until the next session with their analyst. Today, people expect much more immediacy in their relationships, in their communications, and also from their providers. They are not going to hold off as sharing important data, asking questions, or relying on some form of digital support until the next appointment that they have. There are many benefits to this and leads to more democratization of the process. But also we know there people might become more vulnerable, and we need to focus on the tools and the kind of support that they receive over time, and whether the tools are work in and operate in a way that we perceive as ethical and professional. There's also the aspect of data-driven therapy, supervision insights, data-driven supervision that where we record some of the treatment sessions or analyze them and provide real-time feedback to therapists, sometimes really real-time during the session on how to improve the care that they provide to their clients. And finally, underlying all these aspects is, of course, the administrative level, which is why we all choose health in the first place, based on our love to writing progress notes and reports and billings and so on. So I will not go into this, but this is, for instance, a really great use case for using automation, not necessarily augmented intelligence, for billing and scheduling and so on. Oops. Okay. And when I talk about the AI-powered tools, I'm really thinking about three different aspects. First, I'm asking, is there any actual empirical evidence to support their use? Second, are there any turnkey solutions, usable tools that clinicians can realistically adopt? And finally, most of the tools today fall short on at least integration with the EHR. And since we as provider, if we prescribe, quote unquote, or assign an app to a patient, we need to not only monitor how they're using the prescribed service, but also document it on the electronic health record. And this adds additional complications to our work and impacts the quality and reliability of data when we do not update the EHR and the patient's record with all the activities they engaged in between meeting us and throughout their week or their month in whatever cadence we see them. And therefore, this is also an important consideration. I think that as academics, we tend to focus a lot on the evidence, but then if we don't plan in advance and really optimized for both making this a tool that is viable and available to people, plus could be also integrated into the EMR, we undermine the impact of the tool, how uh, easy it would be to use it, and whether the reporting would be still in compliance with the requirements of the law and HIPAA regulations. So in terms of the current landscape, what we see that works today, there are a few areas where AI is clearly operational and effective. We see that in documentation, ambient AI. That's what I did in my previous company at Eleos Health. In measurement-based care, this is a pretty straightforward application. And also in narrow digital therapeutics, mostly interventions. If you, for instance, you think about the VA suite of apps, uh, specific apps for specific conditions that uh, don't rely too much on relationships or on therapeutic alliance, or do not address the patient's social determinants of health and other comorbidities, but they're effective and they work. What still does not work well, and where there are still persistent challenges, appears in three dimensions. The first is engagement. Many of these tools report high drop-off rates in apps that are not generative AI. Amit Baumel in 2019 already found that after 15 days, only 3% of the users who downloaded an app continue using it. We know we have a huge, urgent public health problem with general purpose AI companions. And of course, many tools are not validated in rigorous ways, and we have some progress, but it's absolutely uneven. If I move gradually to our focus on family-based measurement-based care and interventions, one of the key limitations becomes very clear when we move from individuals to relationships. Most AI models are trained on individual level data and integrate just one individual. The tools that I've seen so far engage different family members in different ways and then send each other the information, each participant or each family member or each group member. The tool sends a summary of what the other person thought or are experiencing or reported, etc. But there is no facilitation of real world interactions. And when these models rely primarily on individual data, they miss crucial aspects that are key to adherence and treatment compliance and execution at the home. Relational patterns, power dynamics, systemic factors, and so on. Even if you think about the data sets that are currently available to train on, if you want to build a tool that is based on AI for, let's say, family therapy, where do you get examples from? If you'll go online, what there may be on YouTube, 20, 100 sessions that are specific examples, primarily with uh, mock sessions, primarily with students who play the patients and therapists who plays a specific segment of the session. When I'm looking at this and then on the availability of data, I realized that there are no available data sets to train an AI model on relational therapy and how interactions with a number of people actually occur in real time. And I think that many of the tools that we see today are um, for I think for lack of better description, ChatGPT wrappers. And there's this really creates a mismatch between how models are trained and how care actually unfolds in relationships. In terms of, AI-driven apps and chatbots, we're still very early. There are still very few tools that are both clinically grounded and safely deployed at scale. I gave here two examples, one paper by Nick Jacobson from Dartmouth and his team, and critique or a letter about this tool and the study that they published. Uh, we see that there have been recent trials that show promise, but they also raise many questions about whether the data could be generalizable. Is the tool safe? How engaging it is outside a setting of specific clinic or a study where patients often receive reimbursement for their time for completing assessments or even for completing sessions. And therefore, because we have very few tools that have been trained on clinical data sets with ethical guardrails, we, as clinicians, if we would like to prescribe something to our clients as a tool, there are very few options that are clinical grade and are available today. And based on my knowledge, there are no tools that are based on artificial intelligence, grounded in data and theory, and that we can assign to our patients population today. And of course, since there are very few tools, one of the limitation is that there's very poor EHR integration and incorporation with the workflow. So to summarize this section before I delve into offering relational AI as a use case or case example, um, I'd like to summarize what I think is the core issue. Clinical AI in terms of documentation and clinical and decision support. There have been advancements and we see progress in these areas. In terms of patient-facing tools, there are apps and chatbots for individual level. However, if we can articulate what the problem is and then also assign a treatment plan, the real issue still remains care execution at the home. The home environment is where decisions are made, behaviors are carried out, adherence either happens or doesn't. It's always much murkier and more complicated than it feels like in the clinic. And as a clinician myself, I know that the clinic is complicated enough. But this layer is largely unaddressed by the current AI systems. And we do not have tools that can offer support in terms of family dynamics, allocate different roles and responsibilities in behavior change, and invite family members to become accountability buddies and help with the translation and execution at the home. So I think that, if we really want to help our patients, they have many options to do work on their own. But the critical gap is that we design care for individuals, but then care is executed by families. It's managed by spouses, partners, adult children's, home aides, visiting nurses, any caregiver who cares about the patient, knows how to help them really engage in what they were asked to do, and monitor and provide instrumental and emotional support to the behaviors that need to take place. We know that families work in pulses. They come and go, they work sporadically, and when they're unsupported, the care plans just quietly break down. People mention family members. We've all been cared for by caregivers, and many of us already serve as caregivers to adults in our life, or can see how we will be supporting of a grandparent, parent, maybe aunt or uncle that we care about greatly. And these people many times need help, missed labs, appointments, closing the loop on specific visits, delayed medication changes, escalation that could have been prevented. The system assumes execution, but we haven't built yet the infrastructure that allows for it. I think we have another not only data problem, but also design problem. Um, the last thing I, as a provider and a psychologist, want to build is another tool where people will just engage with it separately. If we look at the news, it doesn't feel like healthy communication skills and support networks are improving. So we really need to rely more on other people in our lives. That's how humans managed distress throughout evolution. Our brains are wired to seek the support of another human being, primarily in our physical environment when we're at times of distress. And the current apps and chatbots, even those that are available for couples and families, do not really invite and reinforce real-time communication. Um, and when I'm considering apps for couples or families, I'm wondering, does it account for relational dynamics, or is just, oh, okay, these are the roles and here's an Excel sheet distributing the responsibilities. Can multiple family members access the tool while still maintaining appropriate boundaries and privacy for each of the members? And does it reinforce individualistic approach or more systemic thinking in ourselves and in our clients? So to make this more concrete, I'd like to briefly share how we're approaching this problem at Resolve Together. I'll focus more on the product, not really on the product, but more on the underlying design principles and how I'm thinking. And my team and I have been thinking about designing for relational care, and what it means to build artificial intelligence systems for more than one person at the same time. Okay, so I have no idea what happened to the title, but I'm pretty sure uh, it said something about when family members are engaged. Uh, we see that all metrics improve. Just looking at the data, we see that there is greater medication adherence, greater compliance with lifestyle changes. And this also said, the last box also said reduction of reduced days in higher levels of care. about 20% reduction. And this is not new data. It's something that is very that has been established over the years. And we've also seen similar metrics in, not to the same extent, with companies that administer and offer tools for increased adherence over time individually. It's clear that when family members are engaged, um, healthy behaviors over a long time could be reinforced in a sustainable way. Um, the idea is not new. We've all been raised in a family, and we know that when things work well, it's the best experience, and when they do not, it can be more complicated. What is missing right now is really or has been missing until now is a scalable way to operationalize families. And this is what we're building at Resolve. The approach that we're exploring is to combine human coaching plus AI coaching that is multi-person conversational AI in a way that supports both the patient and their caregiver, either a family member, a spouse, a partner, the adult children spread all across the US or the world, and they want to help, but they don't know how, and they don't have the mandate or the language or the skills or the tools. Or it could be a sibling or a homemade or a visiting nurse, anyone in the patient's social support network who'd like to help and doesn't know yet how to do it. And the goal is really to translate treatment plans into really small, concrete actions that can be implemented together at home. And in this model, the AI supports continuity and structure, while the human coaching provides guidance and oversight, and we teach people how to turn to one another away from the screen and really work together in real life to help achieve a better lifestyle and better health. So I know that the issue of multi-person conversational AI is sounds avant-garde and very theoretical. So I have a brief demo just to illustrate how this interaction might look like. I'd love to play the video, and then we can talk a little bit about the model, and I'll tell a little bit about the company and what we've done so far to generate evidence.
Chronic care is built for one person, but illness happens to a family. What if care included both of them? Resolve starts with a human coach, a real call where the patient and caregiver sit down together. The coach builds a plan and sets up AI sessions for both of them. Coaching them through a conversation together. Hello, James and Maya. It's good to see you both. James, how have you been feeling lately? What's working? What's hard? What to try next? To recap, your goal is to walk 6 times this week, with James blocking his calendar to ensure walking happens and Maya helping with dinner. How does that sound? Then coaching each of them separately. Every goal, every reminder, every step forward from both of them. This is care that includes the whole family. This is Resolve, building the AI infrastructure for family-driven chronic care.
Okay. So maybe we can pause here for a moment if people have a question. Okay.
I have a quick question for you.
Yes, Andrew.
So fantastic. That was really interesting. I wonder if you could say a word about the fact that I saw so many components of a therapeutic intervention there that may not regularly be delivered by a human. How did you compare this, or to what conditions did you compare this?
Great question. So we have a strategic partnership with Hunter College at CUNY, the Relationship Health Research Lab, where we're testing dyadic motivational interviewing approaches uh, that the uh, that the AI facilitates, plus individual sessions, both for patients, plus uh, caregiving burden support sessions uh, for for the family members. We know that they can become quickly disengaged due to the burden and the lack of support that they currently receive. And the we've also trained our models based on hundreds of clinical couple-based sessions of treatments with chronic patients and their partners. And we have a team of clinical analysts who review the information and make sure that the comments and the facilitation that AI provides is rooted in theory and in clinical guidance. In addition to that, part of the key metrics is, or the key components, I think, is that there's another human being in the loop, another family member. So you have, for us as a provider, an emergency contact, someone who can intervene in real time. This is not people having uh, long-term relationships and very long conversations with AI companions with no external eye. The human component is embedded in this model, not only that they the both the human coach and the AI coach receive the data from the health provider and from the EMR. They work in tandem, plus the family works in tandem. So you have here many aspects for monitoring and human in the loop review. In terms of the clinical data, this is still early on. We're assessing this. That's why we have a strategic partnership with Hunter College to design and test this model. Does that make sense?
It does. We can go on. I have other questions, but we can go on.
Okay. Happy to pause if there are any other questions about the technology or how we're thinking about implementing this type of tool.
I just have a question. So, even with engaging couples as a human therapist outside of the AI can be a challenge, right? Getting two people involved. And I was just wondering, how can the AI be leveraged to engage them in the first place as a couple to do this therapy? Like, how do you get them to use it? And what are some of the barriers? These might be older couples, for example, they have chronic disease. Like, how can those barriers be addressed with the AI?
Um, well, I think, first of all, I completely agree about how complex it is to engage humans on the individual and the couple and the family member and the community level. Before founding Resolve, I uh, gained 20 years of experience in working with couples in person and then using telehealth, and I know how challenging it is. I think some of the barriers that we have as human providers, especially this day and age, can be overcome with AI or complemented by the AI, the fact that it's available outside regular business hours, that it can provide the support that seems to be highly in demand today in the moment. The fact that it's more flexible, you can have a session with your spouse, you can still continue working on your own things and your own barriers to implementing the treatment plan. You can go back to your provider and say, hey, I realized, when I sat with you, I really didn't understand that part of the recommendations, but now I have questions and reservations, or after I came back home, we realized that it's not realistic for me to do this and that, and so on. I think that also AI here can provide, there are different ways of interacting with people. It can be a conversation, it can be a phone call, it can be texting. So I think there are many barriers that AI can help us with. And this is still, it's not a replacement for the human connection, for the reliance on your family members and on the people in your corner, and not and a replacement for therapy and for working with a provider. Okay, so really just a few more comments in terms of what we've done so far. As I said, we have already early design partnerships with also a few community-based clinics whose logos I did not include here. We've already trained the models using proprietary data sets and received feedback from 30 dyads that Resolve is highly usable, engaging, and also safe. In terms of our team, my co-founder and I bring, extended experience in medical AI, and we have a group of advisors that are either a couple of therapy researchers, come from NIMH or the VA or from the industry. And I think what I really was hoping to achieve today and in this discussion and start opening the conversation on the bigger vision. If we think about healthcare as layers, the clinical layer is well developed in terms of diagnostics, treatment plans, provider workflows. I don't need to say that to people who work at UCSF. I feel that what is less developed is the relational layer, the space where people support each other and in actually following through in processing what it feels like to have a chronic health condition. I know from lived experience that when I was diagnosed with a chronic health condition, despite I think that I had already 15 years of experience as a provider back then, I also did not follow my treatment plan completely and also fell off the wagon. And it was only when my family members got involved, especially my husband, and he took more active part in how we deploy the recommendations at home and the lifestyle changes that were required in the entire family. This helped me understand that despite the intellectual knowledge that I have, activation and engagement at home is much more about than just understanding or even coming to terms with the fact that you have a chronic condition. It includes much more deliberation, much more reliance on other people. I tell my patients very often that environment is so much stronger than willpower. And what I would love to really invite everyone is to think about how we build the additional relationship layer that healthcare has been missing. And that is where, to me, behavior change actually happens in those 167 hours outside the clinic, and where much of the opportunity still lies. I would be remiss if I wouldn't compliment health providers in California for really pushing the field forward from a policy perspective. We are starting to see the movement, particularly around transparency and safety in AI systems that I personally welcome as both a provider, a mom, and an entrepreneur. I think that it would benefit our patients and also the tech companies much more. Although some of these legislations are not advancing as quickly as we would have hoped, I think they are still very much necessary. Finally, we have a few minutes for a discussion. Thank you so much for participating today. I would really love to hear a little bit about your thoughts, your questions, criticism, comments. Happy to continue the discussion.
Thank you so much. This is a really fascinating product. And as you know, my perspective as a couples researcher, I think you're really filling such an important gap in our healthcare system that is really being neglected, which is the importance of families and couples. I can see so many possibilities with this product. It almost seems like endless of what the AI could be leveraged to address. And I was just wondering a little bit about, some of the patients that our group deals with often have, multiple comorbidities, multiple social and health related challenges. I guess could the sessions be programmed to kind of flag those other comorbidities? So if like depression is coming up, if the AI can kind of detect depression, for example, in a conversation, could it potentially, triage people to some sort of depression-focused couples therapy or whatever social service they may need related to their situation? Is that something you envision this doing?
I absolutely envision it doing, right? But currently, everything that you mentioned is a different product, different company, separate AI training, um, and therefore we will need a holistic solution. Uh, for me specifically, I don't have a data set to train a model on to detect depression. So I am not even going to claim or assume that I have the capability of doing this. And if I were to include something like that, it would be integrating it with another tool. This is why, a setting like UCSF has more
Yeah,
opportunities in that regard.
right.
For the specific use case that you mentioned, just based on the audio and detecting depression or other mental health symptoms, the company Kintsugi that recently went under, they developed a model to assess respondents, primarily depression, but also anxiety from, or I'm sure just about depression, not sure about anxiety, depression based on audio. And because they went under and the financial model was not valid, they put all their data out in open space. So everyone can use their data. The company's name is Kintsugi, so you can check it out. And unsurprisingly, they're in the Bay Area.
John, did you have a question?
Are you talking to me, Andrew?
I am. I thought I saw your
Okay.
hand up. I know that Lakshmi had a question too.
Go, Lakshmi. I'll go after.
Yeah. Hi, this was such a fascinating talk. I absolutely loved it. And your demonstration was also very useful in understanding how this is going to play out in a family structure. But I was curious how you had implemented the human in the loop. I know you briefly touched on it, but if you can talk a little bit more about how you actually went about doing it, because that seems to be the biggest sort of pushback against using AI chatbots.
Mm-hmm. Yeah. So there are different places where humans are have been integrated. First, we trained the model based on hundreds of sessions of dyadic motivational interviewing where there was a human in the loop and a supervisor who Amy knows very well, who reviewed the treatments that were deployed. In addition to that, you have like the human aspect is baked into the model with the provider that assigns this and still continues seeing the patient, with the AI, with the human health coach who's there in the loop, with the partner who's involved, and there's they're included in the consent, which the patient can always withdraw. Plus, we also have a group of clinical analysts who review the data and flag any concerning interactions. Until now, there hasn't been any. We've put many guardrails in the training of the platform, and it can also, refer people back to their provider. It's not, it's not ChatGPT or another AI where we optimize for engagement. We optimize for outcomes. So the AI can also say, I don't know, or maybe talk about this with your
So what
provider.
is your underlying LLM that you've used? Did you build your own or did you leverage an existing one?
It's a mixture of both existing LLMs plus our own.
Okay, great. And do you think this has any applicability in low and middle income settings at all? Like, have you ever thought that this could, not in the short term, but maybe in the long term?
In which settings?
In low and middle income settings, like
Oh
Sub-Saharan
yes,
Africa.
absolutely. This is going to be deployed in rural Missouri, rural Indiana,
Mm-hmm.
Medicare, Medicaid clients in Maryland, Virginia,
Mm-hmm.
and
Okay.
DC.
Mm-hmm.
So already, I did not include the logos of these community-based clinics, but it's already being deployed in centers.
Wow. Okay. Thank you.
Hi, thanks for the talk. I think, yeah, it's interesting. I never thought about the sort of the individual level kind of bias in all of the modeling. But I mean, I think the question stems from like all the M Health, like the app-based research that exploded. And I know you cited that like whatever 3% of apps are engaged with.
Mm-hmm.
And, I really struggle with it in terms of understanding, like, for example, if it's whether it's TikTok, Instagram, or Google Maps. I'm trying to think of like the high usage apps. I don't know what if that usage is driven by a function of just the investment in marketing, in engagement, as you noted. I mean, that's what the companies are built off of, and that's why we engage with those apps all the time. Um, because the sort of counter to that is that maybe there's classes of people, some
Mm-hmm.
of which are more eager and open to using an AI assisted tool, some are less so. And so how do you think about the optimizing for who this works best for, rather than, I think we could potentially go down this hole of like we're building these tools and maybe the clients don't want them. And so how do
Mm-hmm.
we better understand who's this for and optimize for uh, that subpopulation that I think would be benefiting so we don't get the 3% sort of outcomes that
Yeah.
we don't want.
Okay, these are really great questions, John. You touched upon a couple of issues. First, the data on engagement in apps is a study published by Amit Baumel and others in 2019 on the old school apps, with no generative AI components. As we're thinking, I'm still thinking about something that I already thought about is texting Amit. He's in sabbatical in New Jersey and telling him, hey, run the study again on AI companions. That would be interesting. Second, the AI companions are built and optimizing for greater engagement. That is why ChatGPT provides the response and then asks you if you would you like me to da 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 da, and engagement is in many times achieved through immediate reductions of distress, and this is why they're so pleasing and appealing and sycophantic. And whereas our work is a lot of time helping people sit with the distress and adapt to the changing reality of having a chronic condition. And it's really not in sync with how we operate as health providers oftentimes. And that is in terms of the training and what each of the different apps or platforms optimize for. I want people to talk more with their partner and to call their parents more and help them, not just yell at them, why are you like just complaining about your health, or why didn't you go to the doctor, or just have more conversation outside the platform. I'm pretty fine with that as long as I can facilitate real world outcomes. And finally, you're absolutely correct. There isn't a tool that is for everyone. Just like in any treatment, medical, behavioral, uh, maybe just oxygen and water are universal. All of the other things, on the other things we can argue. Um,
Thank you so much. I see we also have a question from Judy Auerbach. Maybe we can get that in quickly here.
Okay,
Okay.
quick, sorry. Thank you so much. Really interesting and excellent presentation, Shiri. Kind of following off what I was interpreting as part of John's question and what we were just talking about. The discussion sounds to me very parallel to one we have around prevention, HIV prevention technologies, which is who is deciding what to develop and what to test and then implement. And that leads, and now, there's this whole question about choice and optimizing choice in HIV prevention because we have oral, vaginal rings, oral pills, long-acting injectables, and so on. But the question always for many of us as social and behavioral scientists is who's determined in the first place what to even begin to explore? To what extent is community, however one wants to define that, users is a more popular term these days, been engaged from the beginning in determining what might be attractive. So the question is, to what extent have community representatives, patient representatives, whatever you want to call them, consumers, been engaged before any of these app-like things and bot-like things have been developed?
Yeah, I can talk only about myself and what I'm building. We have an ongoing caregiver group and patient focus groups where we also reimburse participants for contributing their data, and they provide feedback on their needs and what they would like to see and where are the gaps for them specifically. I can also say, from one of our clients is an adult day services program in Maryland compared to community-based clinic in rural Missouri. These are two different patient groups and caregiver groups, different communities. We have to ask them all the time. And at the end, the proof is in the pudding. If they don't like it, they're not going to use it. No one is forced to collaborate or complete app sessions. And but I think, yeah, it's critical to hear what they're thinking.
I think Judy's point raises just an important point overall about the importance of industry and academic partnerships as well, because all of us can do all this formative work for you if you'd like. I mean, we're all trained on, human-centered research and putting community and humans' perspectives first. So I could just envision grants being written between industry and academia to kind of do this important work because you're focused on the company and the product and not necessarily, on the research side. And that's where the partnership can really be kind of a win-win situation.
Absolutely. Win-win-win, because at the end, the winners essentially would be the patients and their family members
Exactly.
living a healthier life. Yeah, I absolutely welcome collaborations. I have no problem assessing my tools and reiterating if needed. Anyone here who developed an intervention knows how many iterations are included. Sometimes they're official and sometimes they're unofficial, and happy to talk, about grants, especially those who prioritize greater inclusion of technology. These are absolutely things that I would like to explore.
Great. Thank you so much. Well, we're 4 minutes over, but this was just such a wonderful talk. And thank you again for coming and talking to us about all the work, amazing work that you're doing. And I'm sure others on the call would, be interested in maybe continuing conversations about how can we work together with industry to build the best products possible for our patients. So thank you again. And Rochelle, is there anything else?
No, thank you.
Okay.
Yes, thank you for inviting me.
Take care, everyone.